Good afternoon. This is Ryleigh Clark, and today I'm going to be reviewing ventricular tachycardia mimics, more specifically with hyperkalemia, and why we should know how they present on EKGs. Potassium is the principal intracellular cation, and maintenance of the distribution of potassium between the intercellular and extracellular compartments relies on several homeostatic mechanisms. When these mechanisms are perturbed, hypo or hyperkalemia may occur. So this review will cover hyperkalemia, that is, when serum potassium concentration exceeds 5 millimoles. This disorder should be of major concern because of its propensity to cause fatal arrhythmias. Hyperkalemia is variably defined as any serum potassium level exceeding about 5 to 5.5 milliequivalents, millimoles. Normal ranges being about 3.5 to 5.3. You'll start to see some really significant EKG changes once you get severe hyperkalemia around 7.0 and on up. Hyperkalemia can present in many different ways on an EKG. Everyone's pretty familiar with peak T waves. That's like an early sign of hyperkalemia. Narrow, pointy, prominent T waves. I've highlighted ventricular tachycardia mimics on this slide because that's what I want to be focusing on. And that's when the QRS wave widens and the P waves may disappear. If a patient is tachycardic, this will look like ventricular tachycardia. Useful clues that we'll go over later in this presentation. Compared to ventricular tachycardia, T waves can be sharper than would be usual, and heart rate is often slower than would be typical. And as you get closer to like a 9 to 10 serum potassium level, you'll start to see the sine wave pattern and some severe bradycardia. So hyperkalemia can cause VTAC mimics as potassium levels reach near 8 or 9 milliequivalents. The SA node activity may stimulate the ventricles without evidence of atrial activity, producing a sinoventricular rhythm. This occurs because the SA node is less susceptible to the effects of hyperkalemia and continue to stimulate the ventricles without evidence of atrial electrical activity. The electrocardiographic manifestations of the continued SA node function in the absence of atrial activity may be very similar to those of ventricular tachycardia given the absence of the P waves in the widened QRS complex. So, things you should be on the lookout for when it comes to VTAC mimics. And we'll go over them in a little bit more depth here shortly. When the heart rate is less than 130, definitely less than 120, really wide complex QRS is greater than 200 milliseconds and or one big box. And when you have a variable heart rate. This slide here, this patient was a patient with a serum potassium level of 9.5. And if you look down at the bottom, you're seeing kind of what appears to be a ventricular rhythm. But the key point here is this patient's rate was about 110 beats per minute. And when the rate is less than 120 or 130, think hyperkalemia. If you can recognize this without blood work one day, you may save a life. Here we have a case. It's a 37-year-old male. He came into the hospital. Severe respiratory distress, history of hypertension, diabetes, end-stage renal failure, which should make some alarm bells go off. He admitted to missing his last 2 dialysis sessions. Nurses come in, they get Quick set of vitals on the guy. Blood pressure was 190 over 100, hypertensive. Heart rate of 70. Blood glucose of 200. SpO2 was 80%, and resting respiratories were at 32. The patient did have jugular venous distension and rails on lung auscultation. A patient was administered 100% O2 via non-rebreather, and an EKG was obtained and interpreted as sinus rhythm with an incomplete right bundle branch block. And that is the first rhythm there on the right that this patient had when he was first admitted into the hospital. Shortly after, the NRB improved the patient's pulse oximetry to 93%, but the patient appeared to be fatiguing rapidly. The decision was made to intubate via etomidate and succinylcholine. The RSI was successfully performed, and the SpO2 improved to 100%. But at that time, when a subsequent EKG was ran, the patient's cardiac rhythm changed. And the rhythm on the right is what the doctors saw. The physician caring for this patient noted a regular wide QRS complex tachycardia with a rate of 105. Remember, we're looking for rates less than 120 to 130. This patient's rate here is 105. Patient's blood pressure remained stable, and with the absence of the atrial activity and the monitor interpretation of VTAC, the physician diagnosed this rhythm as stable VTAC. A 1.5 milligram per kilogram bolus of lidocaine was administered via IV, and approximately 2 minutes later, the patient developed this rhythm. That's asystole. Generally speaking, asystole is bad. Standard ACLS protocol was initiated. Unfortunately, the patient never regained pulses. Shortly after the patient was pronounced dead, the lab called to report that the initial serum potassium level was 7.3 milliequivalents. So this patient was a patient that was hyperkalemia, and he had that slow heart rate of 105 beats per minute. This physician followed the standard ACLS protocol and administered lidocaine, which caused this patient to go to asystole. We've got another case here, a real case, a 45-year-old male complaining of palpitations. His systolic blood pressure was 115, and the ECG was showing very wide complex tachycardias. And if you're looking at this, what would you think your drug of choice would be? The physician here chose amiodarone. Substituting procainamide or lidocaine would lead to the same result. This patient bradyed down and died. This is a closer look at that rhythm. If you look at those QRS complexes, regular ventricular tachycardia just doesn't get that wide. And if you see those QRS complexes greater than one big box, in some places here that QRS is greater than almost 2 boxes, take a step back and think about hyperkalemia. So this patient was actually, his serum potassium level was 9.2. So really, really wide complex tachycardic. Greater than 200 milliseconds. If you see that, think tox or metabolic. This is important because if you follow ACLS and give amio, lidocaine, or procainamide, you will kill patients just like this. Give strong consideration to calcium and bicarb. This is another real case submitted by a physician. 72-year-old woman brought in by her family for confusion. She has a history of a hernia repair, subsequent complications, and surgeries. Vital signs, 99.7 degrees Fahrenheit. she had a variable heart rate, and the physician made note of this. The heart rate was ranging from 140 to 150 on the monitor. She says sometimes it would go 142, jump up to 147, back down to 140, back and forth between 140 and 150 on the monitor. Blood pressure was 76 over 31. Resting respers were 22, and the SpO2 was 95%. What would your drug of choice be here? As you look closely, it does look pretty ventricular in rhythm. This physician chose 2 grams of calcium. Here's a close up of that. And if you're looking here, the heart rate is over our 120, 130 mark. QRSs, they're not too wide. So you can see why people could see why this may be ventricular tachycardia, but the physician really keyed in on that variable heart rate between 140 and 150. She knew that ventricular tachycardia should be clockwork regular once it gets going. You may have like a fusion beat or a capture beat here and there, but once ventricular tachycardia gets going, it's clockwork regular. So this physician gave 2 grams of calcium. I believe it was calcium gluconate, but don't quote me on that. After 2 grams of calcium, you can see the changes in the EKG just shortly after. You can see the peak T waves in V4, the P waves reappear, and you've got what appears to be a normal sinus rhythm now. Because the physicians were suspecting this was toxin-metabolic, the patient was given 2 grams of calcium. What happens within just a few minutes of giving calcium? Like I said, there's the peak T waves and the P waves reappear. This patient's serum potassium level was 8.1 millimoles or milliequivalents. That normal level being 3.5 to 5.3. Clinical status was improved, and the patient was diagnosed with acute kidney injury from severe dehydration. Here we have another patient. Similar situation here. Looks like we have very wide QRS complexes and a slow rhythm. I believe this physician inaccurately diagnosed this as because of the stable blood pressure, the physician diagnosed this as ventricular tachycardia and administered an amiodarone infusion, and this patient went into PEA and arrested. After patient was deceased, serum potassium level came back elevated. Here we have a 42-year-old male with dyspnea and weakness. Here we've got the wide QRS complexes, the really, really wide QRS complexes. Some of these QRSs are bigger than one whole box, which is 200 milliseconds. When you see something like that, just take a step back and think this could be hyperkalemia. Maybe give calcium and sodium bicarbonate a chance. If you give calcium to the patient and it's not hyperkalemia, what's the worst that's gonna happen? Maybe their bones get stronger. Kidding. You could give sodium bicarb to everyone in the classroom and everybody would be fine. So if you give calcium and sodium bicarb to a patient that's in VTAC and there's no changes, then yeah, probably okay calling it VTAC and going down with your ACLS guidelines of amiodarone, lidocaine, procainamide, cardioversion. Here we have another patient with a slow heart rate and some really wide, complex QRSs. This patient had a serum potassium level of 8 milliequivalents, heart rate of 115, which is definitely under that 130 and 120 range that we're suspicious of. And I zoomed in on a part here. If you zoom in, you got the monitor reading here of ventricular tachycardia. Now, if you follow the monitor's interpretation of this rhythm, you will kill this patient. So be diligent and know how to read your EKGs. So this patient was hyperkalemic with serum potassium level of over 8 milliequivalents. I've got another one here with just really wide complex really wide complex QRSs. Um, this patient's serum potassium level was over 8.8 milliequivalents. After calcium and bicarb were administered, you can start to see the patient starting to develop like a sinus tachy type of rhythm. You can see the peak T waves and P waves reappearing. It's common teaching in medicine that when faced with a Y complex regular tachycardia, the patient should be treated for VTAC. While this teaching is generally true, the use of traditional VTAC medications such as lidocaine, procainamide, and amiodarone for any of the mimics noted above can actually be deadly. Lidocaine and procainamide are class 1 antiarrhythmics, sodium channel blockers. Even amiodarone, which is primarily a class 3 antiarrhythmic, does have class 1 effects as well. The use of class 1 antiarrhythmics for patients with hyperkalemia, which itself is known to poison the sodium channels, or sodium channel blocker toxicity, can produce such pronounced sodium channel blockade that asystole may result in some of these cases. As such, in some of these cases. To kind of wrap it all up, if you have a patient that's on the monitor and it's showing VTAC, but the heart rate is less than 130, less than 120, definitely start thinking of your ventricular tachycardia mimics. VTAC is usually faster than 130. If you get a patient that looks like he's in VTAC but has really wide QRSs greater than one big box or 200 milliseconds, um, take a step back from the amiodarone and lidocaine and maybe give calcium or sodium bicarb a thought. Think tox or metabolic. Ventricular tachycardia is wide, greater than 120 milliseconds, but rarely is it that wide without concurrent tox or metabolic derangement. And if you have a variable heart rate on the monitor, take a step back and think of your VTAC mimics. Ventricular tachycardia tends to have a steady rate and is clockwork regular. A couple of the sources, and thank you all for your time.